Michael Gold is the Vice President for Clinical Development. Have the lavalier. And the Chief Medical Officer at Allon Therapeutics. And as he will tell you, Allon is almost finished with a pivotal study of a new, unique, original type drug for PSP. And also I wanted to get his insights into the process of moving from targetable spots on molecules to actually what it takes to bring a drug to market. And maybe you'll help us all understand that, Mike.
I appreciate that. Thank you for the opportunity to present. So I think we're going to shift from the very elegant basic sciences to maybe a little bit of the cruder but more realistic issues of what happens when you actually try to take a molecule into clinic. I don't know if this, let's see if this works or not. We are within a month of unblinding the study, so anything I say here you need to understand is a forward-looking statement, so caveat emptor, okay? Just out of the abundance of prudence, just so you know, when you get this close to unblinding a study, we have to be very, very cautious about anything we say. So basic premise here from a clinical perspective is that the unmet medical need is undeniable. I mean, everybody here who takes care of patients with PSP can vouch for the sorry state of the condition and our lack of effective treatments. So the unmet medical need is not a debatable topic, right? I think that in every meeting that I've been in, discussions with everybody, patients, investigators, the general state of treatment for PSP patients is also poor. I think we're very comfortable that current criteria allow clinicians to diagnose PSP patients with fairly high specificity. It is a problem in terms of the sensitivity, okay? And this is a discussion between how far into the process you're able to diagnose somebody versus how early and what stage of severity. And clearly what we've learned from running this PSP study for nearly the last 2 years is that patients with PSP and their caregivers and their families are astoundingly committed to going into clinical trials. Okay, they are incredibly motivated. These are not simple studies. It is not trivial for these patients to participate. And I think, you know, for the most part, I think with no exception that I can think of, everybody that went into our clinical trial at a patient and caregiver perspective has been incredibly committed to doing the best they can for the clinical trial. So I was thinking about how to phrase this, and I was thinking about that movie, The Good, the Bad, and the Ugly. There are some really good things going on in PSP. There's some really, really exciting things from a clinical trial drug development perspective. There are some real issues that also need to be addressed, and I think that this is probably one of the best fora for us to actually bring these to the table. Our experience running this PSP study is that there are superb clinical trial sites out there. There are superb experts in PSP who are able to identify the right patients, exactly the kind of patients that we wanted for this clinical trial. The problem is that there are not that many of them. And so that means that for patients, for some of these patients, it meant getting on a car or a train or a bus for hours or traveling and having to stay overnight because there are no places nearby for them to actually go to a clinical trial site. So this is kind of the yin and the yang. Very experienced movement disorder specialists, expertise, increasing expertise in PSP. There have been now several studies in PSP, so these sites have acquired expertise in how to actually run a PSP clinical trial. You know, it's not like running a Parkinson's disease study. It's not like running an Alzheimer's disease study. The kind of instruments that you use, the raters that you want, the way that you collect data, these kind of things are not always an intrinsic piece of knowledge at movement disorder centers. So there is this kind of burgeoning ecology of sites with expertise in PSP and as well as clinical trial expertise. So the NIP study, the Nocera study, and our study, I think convincingly demonstrate that it is possible to enroll sizable clinical trial populations. Even though it's a relatively rare disorder, it is possible to enroll high-quality patients in a reasonable period of time. So the days of having, you know, a handful here and a handful there, I think we should be very careful about those kind of studies anymore. You know, if you're really going to test something and you have good data behind it, it is clearly possible to do adequately powered, prospectively designed studies. The inclusion-exclusion criteria that have been applied both in our study and in the Nocera study, which are kind of tweaks from the NIP study, are tractable. We did not have a high screen failure rate, okay? Part of that was that our criteria were fairly clear and sites started to screen people ahead of time, so they knew very early on what was coming. But strictly speaking, our screen failure was fairly low. And so I gather was the Nocera study. So these inclusion-exclusion criteria are tractable, they're workable, they're reasonable, okay? So we have a way forward in terms of the clinical trial design. So from our experience, we applied fairly strict inclusion-exclusion criteria, and beyond the fact that they were pretty strict, we didn't grant any exceptions. So Tom Zimmerman, who was functioning as our medical monitor, was given carte blanche, and I never interfered with him, but you know, he was consistent in the application of these criteria. There were no exceptions given, and I can explain to you why there's kind of the real aversion to granting exemptions to protocol criteria. Obviously, we wanted to get a homogeneous population. We wanted to reduce the variance. We wanted to minimize the misdiagnoses. So it's this kind of, you know, you identify who you want to study and you stick to your guns, right? That's the whole idea. So the outcome here is we actually, this pointer is, anyways, we completed the enrollment slightly ahead of time. So actually our enrollment, we closed enrollment about 3 weeks ahead of schedule, and we actually had to put the brakes on a little bit early so that folks who were in the screening chute were not denied access to the study. Okay, so even with these strict criteria, we were still able to get patients in a timely fashion. We enrolled a very homogeneous population, and at the AAIC meeting in Vancouver this summer, we actually presented some of the baseline demographics and baseline cognitive features of this patient population. It's smack dab, it's exactly consistent with what's previously been described in terms of other PSP populations. Some of you know we actually collected DNA from subjects in this study. We have some preliminary results of the DNA. I can't give you the numbers because it's not in the public domain yet, but I can tell you that qualitatively, it's an absolutely homogeneous population in respects to tau haplotype. There's virtually no diversity in this population. So these clinical criteria, okay, these very, very nicely operationalized criteria have yielded both a phenotypically and a genotypically homogeneous population. One of the other things that actually came out of the application of these criteria is that over time, when we saw disease progression, including deaths, the cause of death, the nature of the deaths, or the nature of the serious adverse events were very clearly tied to PSP. There was nothing atypical about the kind of progression that we were seeing or the kind of deaths that we were seeing. You know, aspiration pneumonias, DVTs, fractures, head injuries. You know, if you actually look at a litany of you know, cause of morbidity and mortality in PSP populations, ours could have been taken verbatim from any prior description. And the value of that is that when you're looking for treatment emergent adverse events that could be a side effect of your drug, you're looking for anything that looks kind of atypical, something that's not clearly explained by the disease. But having as homogeneous a population as we did actually made our job a lot easier. And for those of you who've been following the way we did it, we had an independent data safety monitoring board that looked at these data both in a blinded and unblinded fashion. And it was very easy for them to actually discharge the responsibility and tell us whether they were seeing a safety signal or not. So these kind of criteria, this is, you know, again, tractable, doable, it was translatable across 47 sites and fairly easy to implement. So we designed a study actually to look at a novel mechanism. So devuninotide is not by design a symptomatic treatment. And that required us to do a couple of things. You know, so we needed to treat for a relatively longer period of time. And this was not like the NIP study with an aim of looking at mortality, but it also is not a 12-week or 24-week study looking at a symptomatic drug. So our compromise was about 12 months based on what we knew in terms of annual rate of progression. So we treated subjects for a relatively longer period of time, but we also collected biomarker data, both in terms of CSF and serial MRI, to look at data or to figure out whether there was a signal that we were actually impacting pathological progression. So what did we learn? Well, we learned that keeping these subjects in a 12-month study is really, really tough. I mean, there's some investigators here who are smiling at me. This is not trivial, folks, okay? And I have to be honest with you, we underestimated the difficulty that was going to be the difficulty of retaining that number of subjects as their disease progressed in this clinical trial, where because by nature of the sites that we worked with, you know, coming to a site would require substantial travel. Okay, caregiver burnout was not uncommon. You know, the subject just progressed to the point where it just, you know, sorry, can't do it, can't come in. So there are lessons learned about how, if I were to do it all over again, design studies in a slightly different fashion to actually deal with this issue of retaining subjects. Most of the subjects were happy to let us do serial MRIs. There were a few that got claustrophobic. There were a few that, because of the dystonia, it became a little bit more difficult. What was disappointing was actually the low LP rate, okay? And this was, you know, partially, I think, that this population is not used to getting LPs. If these were MS patients or if these were AD patients in Western Europe, serial LPs is, you know, post and parcel. It's part of routine practice. These patients are not used to having this done. I think for some investigators, it was difficult to deal with sort of the getting them and keeping them still for a long period of time. I think that clinical trial sites in some areas are not equipped to handle having to keep somebody for several hours after they do a TAP. So there are issues, but if there's any hope of us actually making advances in terms of biomarkers, we have to get to the point where doing slightly more invasive procedures like LPs is routine, okay? And interestingly enough, the actual LP rate was kind of historical with prior AD studies. But if you actually ask folks who are doing like ADNI-2 or doing some of the more recent Alzheimer's disease studies, when they actually require LPs, okay, when they require it, the rate goes way up, okay? So if you make it optional, people will pass on it. If you have a choice between getting a needle stuck in your back or not, you generally will pass on it. But if it's post and parcel of being in a study and you want to have a chance of being exposed to something that can actually help you, the calculus is maybe a little bit different, okay? One of the things that we did not anticipate was the fact that disease progression would actually interfere with the administration of certain scales. And here I'm going to talk specifically about the R bands, okay? So we use the R bands as a cognitive scale. And for some of the patients whose ophthalmoplegia became really, really severe, delivering visual stimuli became a problem. And the way that cognitive batteries are actually normed, you're delivering the stimulus in a particular way. And when you can't deliver the stimulus, oh, okay. Well, let's see. All right, so that was working. This one is intermittent. So okay, so some of the instruments actually became difficult to administer. So you know, you actually had to increase the font size, and you couldn't present it down. You had to present it up. Some of the patients became very dysarthric. So when you're actually doing list learning and you're trying to elicit a verbal response, they can't talk to you, right? And you can't now elicit the responses in a written fashion. That's not how the scale is normed. So by virtue of disease progression, some of the data that we had to collect became very difficult. Some of the instruments became very difficult to administer. So if we're going to keep on doing this, we're going to have to think about ways to actually collect these kind of data through whatever disease progression we get. Or you actually make disease progression to the point where you become an arthritic or severe, that becomes an outcome measure. But in some respects, you then miss the point of they could be completely dysarthric but cognitively relatively intact. You just don't know, okay? Now the other thing here that we learned is that because this is kind of an in-between space, okay? So if you're doing an ALS study and your primary outcome is mortality, you know how to do survival curves, Kaplan-Meier, Wilcoxon, you know. If you do a symptomatic study and you expect that you're going to retain most of the people, there's a particular statistical approach. We're somewhere in the middle, okay? It's long enough that we're going to have substantial loss of subjects, but it's not long enough that we actually would use mortality as a primary outcome. And so this actually requires a very different statistical approach. I can't get into the details because this is under discussion with the FDA, but you will see shortly enough when we announce it, it actually required a fairly innovative approach. It's, I think, something that the PSP community would appreciate and should leverage off of in the future. Okay. So some of the learnings from my perspective, some of the bad, okay, there's no prodrome. It's difficult to talk about a prodrome to PSP. And especially if you're working in an area where you're aiming to do disease modification and you want to start early, you know, mild PSP, in my view, by the time you get to mild, but you have the full panoply of the gait imbalance, the ophthalmoplegia, you probably have whopping pathology, okay? So if the intent is really to try to get people earlier, then I think we have to start seriously talking about some way of designating a prodrome, okay? But recognizing that, you know, we don't have good biomarkers, you know, you don't have the PIB imaging sort of, or you don't have the CSF markers. I accept prima facie it's more difficult, okay? But I think we need to talk about this issue of a prodrome, okay? We also spend a lot of time thinking about what about CBD? So let's knock on wood that the study on PSP is positive. We would certainly spend a lot of time thinking about how do we actually address the issue with CBD. So Dennis's slide, I think, illustrates part of the problem, okay? The clinical diagnosis of CBD is not pathologically accurate, all right? Now, let's give that and say, okay, it's the same underlying tau pathology, it's just a different, you know, topology to it, and somebody meets current criteria for CBD, and I think that Brad Bovey and his group are doing a good job. There is no decent outcome measure for CBD studies. There are no longitudinal data on rate of progression of either apraxia, dystonia, going from unilateral to bilateral. So, you know, and I'm a behavioral neurologist, so I love the apraxia part of this, but there are no good data. So as much as, you know, people have reached out to us at the level of investigators, family, subjects, you know, wanting to do something in CBD, the answer is it's not ready for clinical trials. There's a lot of work to be done to get CBD ready for clinical trials. There are no positive biomarkers routinely being used. So what we see are sort of negative predictive value biomarkers. So people get occasionally an LP to rule out Alzheimer's disease, or they'll get a PET scan or SPECT scan, but there is no biomarker with a positive predictive value. Okay, so that's also a challenge. What's interesting is that, and to everybody that we talk to, of course, you know, it's in the textbooks, it's in the papers that either a lack of response or a transient minimal response to L-DOPA is considered as a reasonable sort of sentinel event in a typical Parkinsonism that you're dealing with something like PSP. But what's astounding from my perspective, you know, having run these trials, is you have documented lack of response, but people are kept on the medication. I'm sorry guys, if I'm upsetting somebody, I apologize before. I don't get it. I just don't get it, all right? We don't see routine use of volumetric biomarkers in the clinic. We don't see routine use of midbrain area or superior cerebellar peduncle as an outcome measure where people say, you know, it's a typical Parkinsonism, it didn't respond to L-DOPA, and midbrain area is below whatever it is, it likely to be PSP. So we don't see that, and we didn't, you know, I think that this is an area where we could focus to improve diagnosis. Kind of a pet peeve of mine because I spent many days looking at adverse events and medication records. So PSP patients are treated with anything and everything under the sun. On average, our patients in the study were on 8 medications each. The range was 30, okay? 30, all right? Now, you may know about some of the medications they're on. What you don't know about are the ones that they buy over the counter that are pharmacologically active, or the ones that they're shopping around from other physicians. What you know about are the ones that you're giving them for neurological symptoms. What you don't know about are the ones they're getting from their internist for their hypertension, diabetes, hyperlipidemia, osteoarthritis, depression. These guys are the poster child for polypharmacy, with really no good evidence basis for keeping them on all these psychotropic medications, okay? And some of them actually work against each other. So I understand there's a problem with urinary incontinence and urinary urgency, but a lot of these folks are put on anticholinergics, and at the same time I'm seeing adverse events of confusion, okay? So on an aggregate, I think there's a real problem with the way the folks are being treated. And like I said, these are not just PSP, they're on everything, okay? There's actually a list of what are called inappropriate medications for elderly, and these folks pretty high on the rating scale in terms of the number of inappropriate medications for the elderly, okay? Now the other thing is the polypharmacy for some of these folks actually prevented them from coming into the study. They were on medications for which there was no evidence of efficacy, for which the treating physician wouldn't take them off, so we couldn't bring them into clinical trial. So it's not a benign thing, all right? It is not a benign thing. All right, so on the ugly side, preclinical. As I see it, and again, I may have a more primitive view of it, there are no good models for PSP, okay? And in my world, I think the lack of non-transgenic models is a particular problem. I worry about the reliance on transgenic models, and this is coming from wearing the scars of working on Alzheimer's disease for the last 15 years, where we used and relied on these transgenic models as a translational vehicle. And for those of you who follow the news, to some extent, the failure of bapineuzumab and solanezumab can be put squarely on the shoulders of the fact that the translation from these transgenic models to a sporadic form of the disease has no positive predictive value, or had none. So we use it, but I think we need to be cognizant and recognize that until something actually works, the positive predictive value of these, MAPT or tau mutation models is unknown. We don't know how useful they are. Now, I recognize that it demonstrates some sort of target engagement, and they have some utility, but I sort of stop there. Okay. This is clearly what we've seen with Alzheimer's disease, and I kind of like Karl Popper's notion of falsifiability. Okay. So right now, what I've seen is that treatments based on response to transgenic models don't generalize. Okay. The lack of these preclinical models, I think, limits hypothesis-driven biomarker identification. And so I was actually very pleased to see some of the data about this large-scale exome sequencing, because in some ways it's hypothesis agnostic, and you can start from the bottom up. There are enough PSP brains, there are enough PSP samples, it's a large enough population that this could actually be a bottoms-up approach. And for those of you who don't know, samples from this study are going to be biobanked at UCSF and are going to be made available. Okay. Now the other problem I have with it is the phenotype. So it goes back to conversations a long time ago. So there are models of gait problems in rodents. Okay, but I'm not sure that those models really replicate gait imbalance in bipedal locomotion versus a rodent with quadruped locomotion. It's a different walking system. Okay, balance is a different story when you are 6 feet from the ground, and you either roll over or you hit your head hard, right? And the same thing with executive dysfunction. I have a fundamental question about when you talk about executive dysfunction in rodents. There are several 100 million years of brain evolution separating us. We can infer behavior, but I'm not sure it's executive dysfunction. Okay. And so I think we have to be careful about how far you can push those models and saying that they're actually translatable or generalizable to the sporadic condition. All right. In the clinical trial section, okay, the current scales that we're using, like the PSPRS, the CEDAL, all those things, they're decent scales. Okay. The FDA likes them. They have reasonably good psychometric properties. Don't mistake that. They actually need improvement. And some of the things that we picked up here is we saw a lot of floor effects. And I'll give you an example of one of the things that bedeviled us. We had patients who came in who had actually fallen and had a fracture and couldn't walk. Right? And on the PSPRS, it's ambulation heavy. All right? It's one of the domains. There's no real way for you to say can't walk because they have a cast on. All right? So it's in the way the instrument is collected, it's a little difficult to be able to actually qualify that. There are issues, like I said, with a profound dysarthria or the ophthalmoplegia with the cognitive batteries. So my plea to those of you who have some interest in here is these batteries actually are like I said, they have decent psychometric properties, okay, but they could use improvement. And actually, Dennis alluded to one methodology, which is item response theory approach. So one of the problems that we have here is that they're non-linear in their properties. So we don't have good data that show that for every point change, or 10% change on the CEDAL, that going from a 0.1 to 0.2 means the same as a 0.2 to 0.3. This is what actually troubled the multiple sclerosis field with the disability scale, the EDSS, is a half-point change doesn't mean the same thing going from here to here as from here to here. And I think we actually need to go through that validation process with the clinical trial scales for PSP to make sure that we have that kind of linearity, because that actually allows us to work across the broad spectrum of severity. Okay? Missingness. There's a problem with missingness, with disease progression. So there's a concept of missing at random versus not missing at random. And my impression from looking at the data that we've been seeing in terms of what's missing is that it's missing not at random. It's missing because the disease is progressing. And when data are missing not at random, it's a problem from a statistical perspective. You can't impute it. Okay? It's not kosher to impute data that are missing not at random. All right. We talked about this, the disease progression and missing data. So travel to sites, to and from sites, was a real big problem. And I think that we try to bend over backwards in terms of accommodating people with overnight stays in hotels, extra money for travel with a companion. But nonetheless, my take home from this is that it rendered subjects exhausted. It created issues for sites, okay? So one of the things that we actually explored, but we got into it a little bit too late, was to actually allow home visits. And the problem with home visits was actually that we have to train entire cadres of nurses, home visiting nurses, to administer these instruments, and that adds to the variability of the instrument. One of the things that we picked up, so one of the things that we did routinely in the study was to look at the distribution of the data. It's a standard thing that, you know, us industry hacks do. We look at the distribution of the data, and we always look for outliers. And the reason we look for outliers is we're looking for biologically implausible changes from visit to visit. And when we see those, we actually query the site and say, help me understand why somebody either improved dramatically or deteriorated dramatically from visit to visit, when the overall progression should be actually quite minimal. And one of the things that we found was that when there were changes in raters, we had dramatic changes in scores. And when you actually went back to the original rater, you regressed back to the mean, okay? So the issue with collecting data at home is it added variability because we would have to introduce yet another set of raters into the study. How do we, is there a technological solution to this? Maybe. Had we incorporated this early and actually gotten everybody trained up at the same time, maybe we could have managed it. But I think this is something that we need to think about if we're going to do PSP studies, is how to be able to evaluate people at home. We had issues with transitions to assisted living, loss of the caregiver, people who either came on or came off medications in the middle of the study because of either PSP or comorbid conditions. This is one that I actually want to talk a little bit about. I don't know how you can honestly handle subject expectations for folks who know that they're facing a rapidly progressive terminal disease, right? There's probably a distribution of folks who understand that, the odds of this working are relatively small. There's probably another distribution that have probably unsustainably high expectations or belief that this is going to work for them. I can tell you that one of the things that's been shown empirically, okay, is that when investigators set low expectations, the placebo response is actually low, okay? But when you actually are pounding the drum and saying, we think this is the next best thing to sliced bread, all you're going to do is you're going to add to my placebo response and you're going to add noise to the study. So I think that, it is important that folks who are doing these clinical trials at an investigator level that you ladies and gentlemen control communication to the subject and create absolutely no expectation. Not that it's not going to hurt, but no expectation. We have absolutely no idea what this is going to do. This is why we're doing the study. And this is actually one of the most helpful things that you can do to actually keep the study effect and placebo effect under control. So we had issues with trial logistics. Rater turnover was a problem. Raters at clinical trial sites are in the low end of the totem pole. It's the low end of the feeding chain, right? Rapid turnover, they get moved from one study to another. And as I told you, one of the things that we found that added to variance in our study was changes in raters. One of the things that I think could help this is if you actually cross-train raters in a variety of different instruments so that you can retain them at your site. And yes, they're working on a PSP study now, tomorrow a PD study and all, but if you actually get them cross-trained in a variety of different instruments, they are actually much more marketable. They are more stable. Okay, there's a career path for them, so you can retain them. We used a CRO, and to be honest with you, I don't think there are too many CROs that have expertise with PSP. So when you talk to CROs and say, what do you know about rare disorders or atypical Parkinsonism, you kind of get that deer in the headlights look, okay? So it's important if you're actually thinking about doing this and you're working with somebody, recognize that contract research organizations do not have a lot of expertise in PSP. We sought out folks within the CRO who'd actually worked in Parkinson's, Alzheimer's, neurodegenerative, so they had some familiarity with the space. But this is, as you're going to see more and more studies come into the space, there's going to be more accrued expertise. But it shouldn't have come as any surprise to any of us that there were going to be hiccups with a vendor, with a CRO. They just didn't have the expertise. And the other thing that we notice is priority within a site. So I know that investigators are often juggling multiple studies. This one was demanding in many ways, and for some of the sites, it was difficult to maintain the focus on it. And that's just kind of the reality, all right? But my hope is that, again, as we start to see more and more in a steady stream of these studies going in, that investigators are able to actually firewall them and keep them safe. All right. So Larry asked me to talk about some preclinical challenges. So I think here's I don't know that these are right, but I think we need some novel preclinical models, stem cells, novel animal species. I don't know why we're fixated on rodents. I understand they're convenient, cheap, but it's not the only species out there. All right. So maybe we need to think about a different approach. I like this, because this issue of non-hypothesis-driven biomarker development, I said there is the technology's out there, the samples are out there, and I think that we should be able to, in a reasonable time and resource framework, be able to provide some sense of, whether it's plasma, CSF, brain, or combination, some sort of framework that allows us to stratify the risk for PSP. Novel targets that are potentially druggable. So one of the things that we looked at is, what's going on in terms of symptomatic treatments. I don't see anything right now that smacks to me of a druggable symptomatic target, okay? And I think part of what's happened in the kind of polypharmacy is people say, well, let's go after dopamine. Dopamine didn't do it. Let's go after serotonin. Let's combine it. Now let's go after serotonin, dopamine, and acetylcholinesterases. So in some respects, almost every neurotransmitter system has been attacked with no real yield. So I think it's time to think about different approaches. Okay, different approaches. And I love the mRNA. Maybe there's something there you can actually use it as a way to probe for druggable targets. And some of these, like the HDAC, looks like it's a viable thing as well. All right. From a clinical challenge, I think that maybe something we ought to think about is sort of a combined biomarker approach. If you look at somebody who's been given an L-DOPA challenge and it doesn't work, and they have some form of executive dysfunction, and they have a small midbrain area, what's the odds ratio that these folks actually have PSP? And I think that one of the things that we ought to be talking about is, you can talk about expanding this definitive probable possible staging, but if you actually give people an odds ratio, if you can quantify it, then you can say, okay, we can live with the uncertainty that somebody may or may not end up meeting the diagnostic criteria, but it's a way of enriching a population to actually allow you to do a study at earlier stages. So it's just a thought based on the data that I've seen that all of these patients had L-DOPA challenges, all of these patients had scans, all of these patients had cognitive batteries. It should be possible to develop a composite index based on an atypical presentation in some of these biomarkers that says your odds ratio or actuarial risk of developing PSP in 5 years is X, right? And there are enough longitudinal databases that you should know what the odds are. I would strongly encourage that we need to start embedding evidence-based treatment regimens. So I think this is an issue of if the drug doesn't work for you, you shouldn't be on it, because all it does is expose you to the side effects. Okay, and I also think that from the sense of standardizing treatment, it actually makes it a lot easier for clinical trialists to be able to enroll patients, and for sponsors to have confidence that the standard of care for PSP patients is pretty uniform. This is one of the reasons why it's pretty easy to do an Alzheimer's disease study almost anywhere in the world now. Standard of treatment is pretty common. It's pretty standard. I'm not saying that there's no variation, but it's pretty standard. Okay, so I really think standards of care, need to be embedded. I would, in the same breath, say you need to start adopting volumetric measures in the diagnosis. So I think this needs to become much more routine. Okay, and one of the things that we're going to be putting out there is we actually work with the Mayo Clinic to do the volumetrics for this clinical trial, and the Mayo Clinic has actually found a way to do automated midbrain and superior cerebral peduncle areas. So there are ways to do this. You could, if you do it, you could ask, you could get a measurement and get some notion of where your patient sits in sort of a risk strata. This last one here, caregiver training with an emphasis on fall prevention techniques. So one of my less pleasurable jobs was to actually have to look into every death in the study. And so when I saw people who died because they fell down a flight of stairs or fractured their hips or fractured their cervical spine and ended up dying because of aspiration. So I know I'm preaching to the choir. I know that everybody here knows that falls in PSP is a leading cause of morbidity. I'm here to reinforce the message. It's a leading cause of mortality, okay? And so I think whatever you do at a clinical trial site, part of what sponsors need to do is to make sure that caregivers are getting the absolute best possible training in fall prevention and aspiration prevention, okay? So I think that's, when you go and you do an Alzheimer's disease study, caregivers get educated on behavioral management, or you do something in multiple sclerosis or whatever, even in migraine, okay? There's a certain kind of standard of care. And I think that this is one of the things where CurePSP or other sponsors make sure that the caregivers are actually trained, or maybe develop new techniques for fall prevention. Because this was truly, preventable deaths in our study from falls, okay? So from the clinical trial, again, new instruments I think are necessary, and again, I'm not here to beat up on folks like Larry who dedicated themselves to doing this, but there's a difference between scales that were designed to track severity, staging instruments, versus instruments that are designed to identify or to be sensitive to intervention, okay? You would think at face validity that they should do the same, but they don't. They have different psychometric properties, okay? And so I think that there has to be work done on getting scales up that are sensitive to interventions. And you have to be careful about what domains those interventions you're going to be looking for. It's the old joke about the drunk looking for his keys under the light. That's because that's where the light is. So you have to make sure your instruments are sensitive to a broad range of possible domains where there could be an effect, okay? Clinical trial designs in terms of minimizing data loss due to bias or disease progression. I already made the point about CSF collection. In rare disorders like this one, Bayesian approaches make a lot of sense in the ability to actually collect data in an ongoing basis and actually revise either dose selection, randomization ratios, stopping rules, futility analyses. There are a whole host of tools available to clinical trialists to make the most efficient use of a relatively small population, okay? Regulators have moved very far from the standard frequentist approach where it's just a p-value. And if you actually have a well-designed perspective and study, and you make your case as to why you're going to do certain things from a Bayesian perspective, it's fine. It works. It's not subverting the whole notion of type 1 error. So there are tools available out there that would allow us to have flexible designs to make the most of the patients that we can try to enroll. I would say that there's a need for subject registries and standardized evaluations. Not only is it a matter of identifying patients early, okay? There are some really, really nice papers that actually show that if you know what the rate of progression is coming into a study, and your primary outcome is a change in the rate of progression, you have a fantastic economy in sample size. This is Nick Fox's work looking at change in volumetric MRI. Okay, so if I don't know the rate of progression, okay, I have to assume, I can't make any assumptions, I assume that there's no difference. But if I actually know what your annual rate of progression is on some scale or on a volumetric MRI or whatever it is, I can then design my study not to look at a change from baseline, but to look at a change in the rate. That's much, much more efficient, okay? There's also this issue, if you have these registries, it's a lot faster to get people in a study in a timely fashion, right? And the appropriate subjects go in. One of the things that I also would like to put up for your consideration is the use of methodology like goal attainment scaling as a functional outcome. Because PSP is heterogeneous, the functional deficits are heterogeneous, okay? So for some people, the apathy is more of a problem. For other people, the ambulation is more of a problem. For some people, the speech. So for every patient caregiver dyad, the things that are most destructive, the things that are most bothersome vary. And when you use a blunt instrument like the CEDAL, it kind of weighs them all the same, right? Goal attainment scaling is a validated approach used in educational systems. Ken Rockwood has been working on this. There have actually been trials using this. It actually is a very reasonable approach to allow patient caregiver diets to tell the investigator, here are the things that bother me the most about X, Y, or Z, and you track those in response to treatment, okay? And it's statistically valid. It just makes a lot of sense. So there are things that we can do to actually make the outcomes more ecologically valid. So just to close off, I recognize it's a tough area. No ifs, ands, or buts about it. And anybody that I've talked to, I came out of doing a lot of work in Alzheimer's disease clinical trials, and also in academia. I have to tell you that after having dealt with folks with PSP, it is humbling, all right? So no ifs, ands, or buts about it. It's a tough area, okay? But nothing that I've talked about here from a clinical trial methodology or biomarker stuff is insurmountable. I'm not saying it's trivial, but none of it is insurmountable, okay? And I think that as much as I've seen, and I've been very transparent about this, I think there is a role for patient advocacy organizations to actually start to help to lay the infrastructure for successful clinical trials. Sponsors are not going to develop novel instruments on their own, okay? Thank God we actually found Larry's, something that was validated. But if somebody were to say to a J&J or to a Pfizer, go out and develop a scale for PSP, the answer is no, okay? So this is one of the things that I think, is incumbent on sort of patient advocacy organizations and sort of this community of researchers is to put your heads together and figure out how do we actually improve the infrastructure and methodology available for these clinical trials. And with that, thank you.
I think that's something that I'm sure you've considered.
So I absolutely agree. Telemedicine is a viable approach where you could actually, you could videotape and get a real-time image of attempts to walk or sit or whatever it is. It's deployable. It's available even in places where technology is a little bit rusty. Okay, absolutely. So I think it's very viable, very viable.
I was just wondering if you could comment on the intranasal delivery, whether that presented any unforeseen challenges with the FDA or benefits specific to this patient population.
Compliance was good. And actually, for this population, I think it was appropriate because the dysphagia would have put them at risk of aspiration if we made them swallow tablets. Okay, so we had really no issues with compliance. We had to teach folks to kind of do the inhalation in a cross-handed fashion. You didn't want the right hand up the right nostril to get it away from the turbinates. We had to teach people to let the solution come to room temperature because if you spritz, refrigerator temperature water in your nose is going to hurt. So that's about it. We worried sometimes about patients who, didn't let their caregivers dose them and whether it was going to create a problem with compliance. There's a limit to how much we can control. This was a topic for discussions, and I think the investigators would probably, we routinely reminded coordinators to talk to caregivers and patients to make sure that, compliance was top of mind as well.
I think it's really cool that you can tailor-make an endpoint for a patient by asking them, okay, what's the worst problem happening to you at the beginning of the study, and then you set up a series of milestones that you will then use as your outcome measure. I mean, I'd love to know how the statistics for that work, but
so I mean, again, I invite you to either talk to Ken or look at his publications. So it's like I said, a very well understood, validated approach that educational folks have been using. You take a kid with dyslexia, right, and you figure out what are the top 3 or 4 things that you want to focus on that are most impairing, and you track progress on those, right? Now, what you need to do is you need to make sure you have enough, for a clinical trial, a large enough sample size that the distribution of difficult behaviors is relatively balanced, right? So you don't want to have, one group where the most difficult behavior is apathy and the other one, the most difficult behavior is urinary incontinence. So you need to have a reasonable balance. And we went through that exercise with Ken, looking at Alzheimer's disease studies, and the sample sizes are well within what we've been doing. So it doesn't add to the burden of the clinical trial.
At the PSP meeting in Germany a couple of weeks ago, there was a presentation about the Nocera study, about that the voxel-based morphometry analysis was positive, even though the analysis using the actual outcome measure, clinical outcome, was not.
Right.
Any comments on how that might have worked?
So anybody who looks at data from a subgroup, caveat emptor,
Right.
because subgroup analyses generally amplify effect sizes that are not then replicated because it's a biased subpopulation. All right. Do I think that it's possible, like in any disease-modifying approach, that you're starting to impact the underlying stuff, but there's a lag in terms of actually showing a clinical benefit, or the other, there are other hypotheses. You can impact the pathology, but it's so far advanced that you're not going to see a clinical benefit because the instruments are not sensitive enough.
Right.
So I saw some of those data in Vancouver. It was very gratifying to see that. It bothered me that obviously that there was no correlate with the clinical outcome.
Right. I think the areas of improvement were in the lateral ventricular volume and the superior cerebellar peduncles.
Yeah.
I think that's just FYI.
I mean, this is one of the reasons why. So our original intent was just to look at whole brain volume, and then based on seeing those data in Vancouver, but also, so we had a trade-off. We expected to have a lot more CSF. We didn't have a lot of CSF, so we had the option to actually bank on collecting additional MRI markers, and those midbrain area and SCP areas look like they're very robust. So that's where we're going.
Right. Yes.
Yeah. So, so I agree with you that I think it's fairly obvious that the time at diagnosis needs to move closer to the beginning of the illness. I think one of the problems, however, is that I think as the phenotype becomes more, shall we say, subtle, it also becomes more ambiguous. And I think that will be a substantial challenge. So, for example, you might end up with an analog of MCI, except that in PSP, what MCI would be, or what its analog would be, could be the abortive syndrome or a minor apathy or subtle cognitive dysfunction. And then it becomes quite a challenge.
No argument. I mean, my sense is that if you have somebody with, unexplained frequent falls, evidence on an MRI of midbrain atrophy, and no response to L-DOPA, maybe you should, maybe that's a way to start actually stratifying risk, or an odds ratio. But I agree with you. I mean, I think that this is not trivial. I didn't suggest it was, but I think by the time we're getting them, they're 4 years into the disease, 3 to 4 years into the disease, because some of them have spent 2 years waiting for a diagnosis, at least 2 years.
Wanted to ask you, you said that there would be some things you would do different, and I wanted to know which are those.
So one is I actually would use home visits or telemedicine approaches to actually be able to get out to patients, okay? I would actually have made CSF required, because I think for a phase 2 study, it's terribly, terribly important for us to actually not only look at biomarkers like tau and paired here, but actually seeing whether we get actually CSF concentrations and whether we actually develop antibodies in the CSF was very, very important as well. So I would have pushed for CSF a lot more aggressively. I think I would have probably taken a slightly different tack on the medications that we allowed or didn't allow. Might have pushed a little bit harder to get people weaned off a whole bunch of medications that could actually adversely affect cognitive, function, or could have been a confounder for some of the tests some of the outcome measures.
One thing I wanted to add, and if we're looking to define a prodrome for something like PSP, I think that we may be barking up the wrong tree if we're looking at motor symptoms. And I think that something like behavioral and psychiatric dysfunction may be the way to look. Commonly, when I see people with PSP, if you really interrogate the family, what you find is a 3-year history of something like an anxiety disorder. And so commonly, and even though you're doing it retrospectively, you can define something like OCD or separation anxiety disorder or something like that that is really atypical for the patient. And I think if we're looking at really being more specific, if we apply more and more specific psychiatric syndrome diagnoses to these patients, we may be able to pick them up sooner. And if we're using really specific psychiatric diagnostic criteria and then doing volumetric studies on some of these patients, maybe from geriatric psych clinics, we may be able to define a prodrome to PSP much better than if we're looking for motor signs.
No disagreement, and in fact, if we look at the kind of concomitant, the number of folks who carried a diagnosis, depression was very, very common, anxiety was very, very common, but my worry is that people mistake apathy for depression, and I don't know whether these patients are actually abulic, somewhat, truly sort of frontal apathetic, and it gets misdiagnosed commonly as depression. So, but I agree with you, behavioral disturbances are prominent. It certainly should be part of, scoring of some sort.
Yeah, I was going to ask a different question about genetics, a composite score, but we have a questionnaire that comes with most of the brains, and it asks, is there any change in personality? Almost everybody that fills out that form describes change in personality as being an early, and there's descriptions usually apathetic or lost interest, but there is very common as a very early manifestation. But so what if you combine that with a genetic? We know there are 4 genes, 2 tau and 3 non-tau genes, and you talked about a composite genetic score. I mean, it's used in some other studies. Can we do that why can't we do that right now with PSP?
You
could. You do the genotyping of syntaxin and MOBP and PERK and tau and.
So A, I don't have the resources to do it. B, the DNA will be banked shortly, and when the DNA are banked, you are welcome to request access to it and do it.
Well, I was thinking more in terms of the clinical study design to include. So the psychiatric features are going to be very non-specific, but if you do combine that with the.
So honestly, Dennis, I think that for this patient population, saying that you're going to be stratified on the basis of some sort of genetic marker would work fine. They're already diagnosed. So we had this kind of analog discussion about doing ApoE testing in folks who are already diagnosed with Alzheimer's disease.
Earlier.
Right. So earlier. So I think that when you do that earlier, I think it's doable. But I think it's doable in the context of good genetic counseling as well. What does it mean? Okay. And especially if they're offspring that may have a. So it's doable. I think most of these patients were amenable to it. We got very few refusals to give DNA. So,
Okay.
Right?
Thanks
Thank
very
you very
much,
much.
Mike.